again for having me. It's a real pleasure to be here, and it's always a pleasure to work with the panelists who are absolutely exceptional, but also it's a real privilege to be able to speak with individuals who are really interested in fixing these terrible injuries the way I do. At the end of the day, remember when you've seen a couple of crazy X-rays and maybe poorly executed surgeries, let's always remember that aside from the shock value of X-rays that are shown from poorly done surgeries, remember that there's a living human being that's attached to that X-ray. And so it really behooves us to do as good a job as we can with the resources that we have. So I'm going to talk about intra-articular distal femur fractures, and there is way too much to talk about, even if I spent the entire time, so I won't do that. But what we'll do is we'll just talk about a little bit of the treatment goals of anatomic reduction of articular segments, and then restoration of the articular surface back to the rest of the distal femur, which means length, alignment, and rotation, and doesn't mean putting them together like puzzle pieces. The goal is to allow early range of motion and ideally to allow early weight bearing if you can. And then this is the thing that we've been touching on and that we went through Ms. Ward's talk thinking about is ways to prevent varus collapse that can happen after isolated laterally based lock plating constructs. So take home points I'd like you to have are that first of all, the distal femur has a very unique geometry and anatomy, and so we need to respect that, and I'll mention that as it's relevant to where we place our implants. We want to get our articular reduction in an anatomic position, and then we want to get correct axial alignment when we're reattaching the articular surface to the shaft. Finally, we want to make sure we understand our implants so we know what they do for us, but then what they also shouldn't be asked to do for us. The distal femoral geometry it's really trapezoidal if you look at it from an axial standpoint. And then what you find is that there's some internal rotation, so to speak, of the lateral surface of the distal femur by about 10 degrees. So what you need to recognize is that when you're putting your plate on, it's going to sit internally rotated a little bit at the distal femur. The main reason to consider this is, first of all, that most of the anatomical plates that have been created are designed to match this. But if you, as the surgeon, put the plate in the wrong location, you can induce a deformity that can be really problematic for the patient and for future surgeries that might need to happen on account of a malreduction. You also need to recognize that the distal femur sits relatively posterior relative to the axis of the femoral shaft. And you can see here in the more central illustration that the path of an intramedullary nail ends up really close to the junction between the anterior third and the posterior 2/3 of the distal femur. And so if you're going to be putting a plate on the distal femur on the lateral side or on the medial side, I would say, then you want to consider the fact that the plate needs to be sitting more anterior than you might think. It should not be central. And if you look in the lower right-hand corner, you can see the small shaded box that's labeled W, which would be the insertion point for an angled blade plate. Notice that is sitting anteriorly relative to the femoral condyles. That's really important. If you place it too posterior, then you end up with a bunch of different issues. So if you take this is an example of a plastic bone model where a distal femur fracture has been fixed with an angled blade plate, and you can see that the plate has been placed too posterior. And then, just like the surgeon would do, the plate is reduced to the shaft of the femur, and look what's happened. You've translated the distal femur anteriorly. And then you have to think about this. If you place your plate too posterior, it ends up pushing against the lateral epicondyle. And then your plate, which is designed to sit somewhere different from where you've placed it, will drive the distal femur medially. And what this ends up with is, you can call it whatever you like, whether it's a golf club deformity or a hockey stick deformity, it's a real problem. And you can see this ends up causing a real issue with distal femur deformity. So you don't want to do that. So make sure you know where you're placing your plate. We want to counteract deforming forces, and this is really what we're doing when we're achieving our metaphyseal reduction, right? We want to think about the things that are creating deformity at the fracture, And primarily the big thing, and we've already seen some examples of placing towel bumps beneath the apex of the fracture to resist the pull of the gastrocnemius. What those towel bumps are doing are not only reducing the apex of the fracture, but they're also allowing the knee to flex, which relatively relaxes the gastrocnemius and helps to keep it from pulling the distal femur into an extension type of deformity like you see here. And there are lots of surgical approaches that we can use. The key is that when we address high energy intra-articular distal femur fractures, that we get our exposure of the distal femur articular surface so that we can see what it is that we're doing and we can put things together. So your fracture pattern ultimately is going to determine the type of approach that you use, and if you use more than one approach. You have to think about other things as well. What kind of reduction techniques are we going to use? Direct reduction techniques are most often used for articular surfaces, but indirect reduction, such as use of femoral distractors or other longitudinal traction techniques, are used for metaphyseal reconstruction and realignment. We want to think about whether we're imparting absolute or relative stability to the fracture segments. And then we want to think about, based on what our goals are for the various parts of the fracture, then that helps us determine what kind of a surgical dissection and a surgical approach we're going to use. And then, of course, this gives us an idea of what implant we're going to choose. And choosing the implant should be the last thing that you do. It would be best if you didn't choose the implant and then make your surgical plan based on the implant that you have, unless it's the only implant that's available, in which case, and in many cases, that may be required. So we'll speak about articular reduction here. And there are lots of articular fracture patterns, obviously. And so this is how I would consider approaching it. And I'll have a few photographs of some plastic bone models here where you can get access to the medial femoral condyle. And that's probably the first place to start if you notice that you have medial condyle fractures. You can get access through a parapatellar approach. The type of approach that I would tend to use for highly comminuted intra-articular fractures is a variant of a lateral approach, where I'm making a lateral parapatellar incision deeply, and then making my arthrotomy just adjacent to the lateral aspect of the patella. If you don't like that concept because you would prefer to stay on the medial side of the patella, that's probably reasonable, but that would just entail a second incision where you make a midline incision to make your medial parapatellar approach, and then you make a separate lateral incision for insertion of your laterally based plate. And that's perfectly acceptable. Just be aware, again, of where you need to get, and then make your incisions accordingly. So, but you can get access to the posterior condyle on the medial side, as you see here. You can also consider doing a subvastus approach medially to improve your visualization if needed for the medial side. For the lateral condyle fragment, otherwise termed the Hoffa fragment, you should be able to address this through your lateral incision, right? And just remember that in order to get to this, very often you need to flex the knee, but recognize that when you flex the knee, it can drive the posterior lateral condylar fracture fragment proximally. So you need to be aware that although it may improve your visualization slightly, it could also accentuate your fracture deformity, and you need to work against that. And then what we want to do is we want to recognize that once we've got our posterior condyles reduced, we want to get the lateral and the medial condyles together. So how do we do that? So how do we reduce the intercondylar split? Well, this is the standard way that we think about it, right? So we'll place a clamp or multiple clamps onto the medial and lateral sides of the femoral condyles and just clamp them together. And you are looking at the anterior femur in general when you're doing this. And here's the problem. So you look at that anterior femur and it looks pretty righteous. It looks like it's been really nicely reduced. However, if you look axially, you'll notice that the fracture is gapped in the posterior aspect of the distal femur. And that's a real problem. Now, how do you see that? You can't see that with your eyes. So you get your fluoroscope or your image intensifier, or II, I think you all like to call it. You get your image intensifier in and you take a femoral notch view, which is a similar view that many knee reconstruction surgeons will do prior to performing knee arthroplasty. And you can see the gapping that occurs at the roof of the notch that you can clearly see here on this plastic bone model. And so if you see that, then you need to do something about it. So you don't just accept it and leave it there. You achieve your reduction by a more strategically placed clamp or more than one clamp to be able to get your fracture reduction correct. Now, remember, what we're not showing here is that one or both condyles may be malrotated as well. And so you need to really pay careful attention to make sure you're not flexing or extending one of the condyles relative to the other. And sometimes it can fool you. So you have to pay very close attention to what you visualize. The next thing we're going to work on, now that we've got our fractures reduced, and we're going to fix them with screws generally that are placed along the articular margins so that we leave room for either our plate or our nail or both that we're going to be putting on. Then we're going to achieve our metadiaphyseal reduction, and we do this by paying attention to the overall length, alignment, and rotation. We've heard about a great method of checking rotation after reducing during retrograde nailing. We heard that from Pete a little while ago. Measuring length, there are lots of ways to do this, but in general, these are the goals that we have. And then finally, you want to make sure you know your implant. Know exactly where things are needed to be placed. So if you look at the left-hand diagram here, this is a basic distal femur plate that's available in the United States and probably in many other countries. But notice that there is a clamp anteriorly on the condyles, but you also see a couple of places where either wires or screws have been placed. They are very, very close to the articular margin. And the goal here is that you're keeping those screws, often those are screw heads that you'd be staring at there. Those screw heads, you don't want them interfering with where your plate is being positioned. But you want to make sure you're putting the plate in the correct location. You can see on the right-hand side, this is a template that is used by another implant manufacturer that can be used to figure out where you would like to place your plate. So remember, you want your implant ultimately to be placed properly on the articular segment, okay? And then you can line it up to the shaft. If you place it improperly on the articular segment and then you realign the plate to the shaft, then you will malreduce the metaphysis, okay? And in general, some people talk about summation wires being placed. So if you look in the right-hand corner, you can see there are 4 small Kirschner wires, but then there is a larger threaded guide wire that has been placed through the distal aspect of this template. And notice that it is basically been designed, it's been designed to be parallel to the femoral condyles distally. So approximately a 95-degree angle relative to the femoral shaft. And on the left-hand view, you see that the anterior aspect of the template being used here is more or less parallel to the anterior cortex of the distal femur. Now remember, again, like I just got done saying, implant insertion into the reconstructed articular block will determine your alignment. So if you put it in the wrong place, then you're going to misalign the fracture. This is what it should look like. So this is a blade plate that's been used. Notice there are no locking screws. So you don't need to place locking screws everywhere. This is obviously a fixed angle construct, which is what locking plates were designed to be as well, but all cortical screws otherwise up the shaft. So we don't need locking screws generally in the shaft unless the bone quality is terrible. And then sometimes you can actually use some of these plates to drive your reduction. So if you really have substantial difficulties with figuring out where the bone needs to go, you can use the plate to help you. However, if you put the plate in the wrong place, it's going to drive your malreduction. So try to avoid that. And this is what something might look like when all is said and done. These aren't easy. So in general, for high energy distal femur fractures, but in reality, for any intra-articular distal femur fracture, these are things you want to think about. The distal femur geometry and anatomy are fairly unique, and you need to pay attention to the anatomy with regard to reduction, but also with regard to where you place your plates or any of your implants. The goal is anatomic articular reduction with ideally absolute stability at the articular surface. We want to achieve the correct axial alignment, which means restoration of length, alignment, and rotation, ideally doing this through indirect methods. And then understanding your implant of choice is probably the most important thing, because that is what you're going to do to hold things together once you've gotten them expertly placed into the correct position. Thanks very much.
Awesome job, Greg. one of the questions on the Q&A, which I love the directness of it, was why do we need to be weight bearing these patients fully? And I responded on the chat that in the geriatric population, we're trying to obviate sarcopenia, muscle wasting, pressure sores, vulnerability to respiratory tract infections, etc., etc. But in the younger population, let's say in a 20-year-old, do we really care about early weight bearing? Is it a big deal? In fact, should we be avoiding that in order that they don't go on to deform or break their implants or whatever?
So, sorry, Ennis, you had your hand up, so please.
Sorry.
So I was just, I mean, I think in the younger patient, unless you've got an intra-articular fracture, which you're trying to protect, it really doesn't matter. And not weight bearing the patient is not what saves your implant. I truly believe that failure is going to occur irrespective of what you do with weight bearing in a non-articular fracture. So if you haven't fixed it properly, whether you weight bear them at 2 weeks or at 2 months, it's still going to fail.
Yeah, so as an extension to what he's saying, I would ask, if we're going to limit weight bearing for these younger patients, how long should we do that? I mean, should we do it for, I've heard surgeons say, oh, we should just limit them for 2 weeks. So to which my response is, okay, so how much bone healing do you anticipate happening during those 2 weeks? Right, so although you're right, I mean, I guess that the young and hale 20-year-old who is perfectly capable of using crutches can protect their weight bearing for months if needed. That's perfectly fine. But I mean, why would we need to do that? If you do a good job with the surgery, you stabilize the fracture appropriately, patients are going to auto-regulate their weight bearing based on how they feel. So why not just let them weight bear to tolerance? And if they tolerate it really well because you did a great job with your reduction and fixation, then that's a home run. Okay, so you can just let them go. And if they can't tolerate it, maybe they'll just use the crutches because it hurts a little bit. And then when they don't hurt anymore, then they'll get rid of their crutches. Yep.
So Greg, just to be absolutely clear on that, your reduction, I think you're doing what I do, which is do 2 approaches to these things. Your reduction to the joint is medial parapatellar, and then to get your plate in, you're doing a fairly smallish lateral approach direct onto the anterolateral condyle to put your plate on. Is that have I got that right?
Yeah, sometimes I'll do it that way, but sometimes I use, there's a surgical approach that was popularly termed, at least in the United States, a swashbuckler approach by the UT Southwestern in Dallas, which is really, it's a single skin incision, and it really looks like a basic lateral approach, but you then flap the skin up and then you perform a lateral parapatellar approach, and then carry the fascial incision along the lateral margin of the vastus lateralis, and then incise the iliotibial band with it. So it becomes one incision where you have sufficient access laterally to position your plate, but you also have sufficient access anteriorly to be able to both reduce and fix your articular segments. So I'll use that sometimes. I don't have any problem with making 2 incisions. And I will mix and match these surgical approaches based upon what I see as the fracture pattern and what I've interpreted, and also, and sometimes based upon the quality and skill of the trainees with whom I'm working.
Yeah, absolutely. Absolutely right. Ennis, I think we're with you. Bone loss. We've already had some stuff on the chat about, what do we do about bone grafting? Do you ever bone graft acutely? When do you put in cement? So over to you, buddy.
All to become clear.